Thank you. I'm really glad we have coffee because I was thinking, it's like, oh God, nobody's going to be able to stay awake through my presentation. It's that time of the day. So thank you so much for inviting me here. I think that, as I've been sitting here today, I always feel, I do a lot of speaking around health coverage, access to care. I talk a lot about Medicaid, and it's like Medicaid, the more you know you don't know. And I kind of feel that way now about breastfeeding. While there's, you think you kind of know, and it seems very simple. We heard about this Virginia Fox, Senator Fox. It's just like, we've always been doing it, and that's just the way it is, but everything is a lot more complicated. So what I want to do today is talk a little bit about some of the other things. We've been focusing a lot on talking about kind of breastfeeding in the clinical setting and particularly in hospitals, but I think that we all know it's a lot more complicated than that, and because women's lives are incredibly complicated. So I think after 10 years, as we celebrate 10 years, I think it's also an important time to reflect and think about what kind of the upcoming challenges are. So with that, I'm just going to start. We've had a lot of statistics about, where we are compared to other countries, and a lot of women actually they want to, but they can't breastfeed, or they can't breastfeed as long as they wanted. This is from a survey that I assume many of you are familiar with called Listening to Mothers 3. I think there's hopefully another one coming up. This is, I think, data from 2015. But you can see here there are lots of differences, but I really want to highlight some of the income-related differences are particularly, I think, for lower-income women, they're less likely to say that they do it as long as they had intended to. There's more here than I can possibly explain or understand, but I just really wanted to highlight that a lot of women want to do it, but a lot of women really are not able to do it for a lot of reasons. We talked a lot today about variations, international variations. We have a lot of variations. This is a different cut of the CDC. This is women who have ever breastfed. But we see that some of these are the same states, the lighter states, that have the lowest rates of breastfeeding. A lot of that has to do with a lot of different policies and resources that the states allocate to breastfeeding practices. We also have heard a lot about hospitals, and we know that that it's really important for women to have at least before delivery, during prenatal period, and afterwards. It's really important, but there's a lot more to women's lives than having a child. It's like I always think about there's so much focus on pregnancy, and you leave the hospital and you're like, oh my God, I have a baby. And as a mother of a college student, it's like it's just beginning, right? There's just so much that's involved, and so much in terms of policies that really we can enact to make this whole period a lot easier for women. So what I want to talk about a little bit is workplace accommodations and supports, and what we can do to make the workplace a friendlier place for moms who are breastfeeding, who want to continue to breastfeed, and also what we can do around health coverage and scope of benefits, because we know that it's very important to have insurance pay for many of these services, insurance or Medicaid. And Medicaid is a really critical part of this discussion. Nearly half of births in this country are paid for with Medicaid dollars. So really, when we're talking about making changes, Medicaid really needs to be part of the dialogue, particularly when we're talking about the lowest income women, the women with the fewest resources. So I see some nodding heads, so I'm going to get into it. So Medicaid, again, it's the more you know, the more you don't know. So hang with me here. So I want to talk a little bit about, first of all, when moms return to the workplace, and I just was looking at some studies as I was reviewing this. I focus on a lot of women's health issues, and breastfeeding is not my special area, so it's always an opportunity to learn more. And so when women were asked, what are when they go back to the workplace after having a baby, what kind of challenges do you face? You can see here 28% said that breastfeeding was a major challenge. But related to breastfeeding, you can see here that 15% said they had lack of support in the workplace as a new mother. 21%, 1 in 5, said they had a challenge having their employer agree to the number of hours that they wanted to work, or a rigid or unpredictable work schedule. And we know that women who are low-wage workers really experience the greatest challenges. So what do we know about breastfeeding, maternity leave, and workplace? We do know that moms who return to work before 6 weeks, and about 1/4 of women return within 2 weeks. So this is really a very serious issue for a lot of women. They're more than 3 times as likely to stop breastfeeding as women who return later. We know that when women take short leaves, women who work in inflexible or non-managerial jobs or have kind of low-wage manual administrative positions are more likely to stop. And in the month that a mother restarts work, she's more than twice as likely to quit breastfeeding as a mother who's not restarting. And in Canada, where they have maternity, I was like, oh, from 6 months to a year of increasing maternity leave, I thought, wow, wouldn't it be great if we had that opportunity? At least we don't even have any federal paid leave policy. We do have, in 5 states now, we do have paid leave, but there is no, the FMLA, the Federal Family and Medical Leave Act, is unpaid. And that's really important because for a lot of women, it's not a choice. It is an economic reality. They have to go back to work. So in Washington, California, New York, Rhode Island, New Jersey, and DC, there is paid leave. But we have there was a lot of discussion. Initially, Ivanka Trump had, I think during the campaign, there was a lot of discussion around paid maternity leave, but I haven't really been hearing very much about that recently. One of the things that's also really important is that women are much more likely to work part-time or part-year. And people who have who work part-time or part-year are less likely to have what we call fringe benefits, such as paid leave, such as health insurance. And you can see here about half of employed women with kids reported overall that they had paid family leave. About half have paid maternity leave, but you can see less than 1/4 of part-time workers have paid either any paid leave or paid maternity leave. So we have done and we have made some achievements, and we heard about this a little bit earlier around the Affordable Care Act. We've heard a lot about the Affordable Care Act, but what a lot of people don't know is that it actually amended the Fair Labor Standards Act, which now requires employers with 50 or more workers to offer all their the new mothers reasonable break time for women to express milk and a private space that's not a bathroom for expressing milk. And so you think about all the women who work in markets or in Starbucks or in all of these places, you know, having a place to express breast milk is so important. And they have had an impact. This was a study that was done, I think, a couple of years ago, that there are 2 women who have the break time and a private place are almost 2.5 times as likely to be exclusively breastfeeding at 6 months, 1.5 times as likely to continue breastfeeding exclusively with each passing month. However, not a lot of women, even though we have these laws, not a lot of employers are complying with them. 59% of women said that they had reasonable break time to express breast milk. 45% of them said that they had a private place that's not a bathroom, and 40% said that they had both of these options. So you can see here that while having the policies in place is important, we need to have oversight and we need to have education so that when employers know that this is required of them, and also women know that this is their right. And I think that that's really kind of an important challenge in terms of educating both employers and women. The ACA also made important changes to insurance coverage of maternity care. Before the ACA, we did have the Pregnancy Discrimination Act, but it only applied to employer insurance. If you had individual insurance, pregnancy was a pre-existing condition. A handful of states had maternity care coverage requirements, but those were a very limited reach, and women who purchased and insured individual plans basically had to purchase very expensive riders. And in some cases, those riders were even more expensive than the actual insurance that they were purchasing for all the other health services. The ACA requires that all insurance now cover maternity and newborn care. It's an essential health benefit. Pregnancy is no longer an pre-existing condition. Now all United States Preventive Services Task Force recommendations, pregnancy-related and other, have to be covered without cost sharing. That includes prenatal visits, which are defined as well-woman visits, and breastfeeding services are covered without cost sharing in all private plans. And I was part of the Institute of Medicine committee that actually made the recommendations for preventive services for women. A lot of the discussion has been around contraceptive coverage, but I can tell you, behind our closed doors here, because we're not supposed to talk about our deliberating process, when we came up with the breastfeeding recommendation, it was a no-brainer. It was like the evidence on the impact and the power of breastfeeding to protect children and to protect women. We have the research, and so this is an area where I think, like, you know, we have a lot of research. We don't have a lot of research on a lot of the details, and today I've been learning about banking and and all of those. I think there's more research, but in terms of the power of breastfeeding, in terms of improving health, the research is there and it is strong. So now all plans have to cover, plans and under Medicaid, the expansion has to cover breastfeeding education, lactation counseling. So, and that includes lactation consultants, breastfeeding counselors, certified midwives, certified professional nurse midwives, the list is up there, equipment and supplies, and that includes double electric pumps, not manual pumps, but you have to really, as medically necessary, and also milk storage and maintenance. So this is really, really important, but we still have areas to go in terms of reach. I'm going to take a little station break here because I think this is a really important issue that we haven't really talked about today, which is the importance of coverage and having coverage for women. So the Medicaid expansion is a key to getting coverage for women. And we know that many states have not expanded Medicaid. So what that means is that while a woman may be eligible for pregnancy-related coverage under Medicaid, at 60 days postpartum, she loses that eligibility. So 33 states have expanded Medicaid. They're shown in blue. We just had 33 states. We just had a few states now expand, Virginia and Maine. And so those women have the same benefits as women with private insurance. And I just want to remind you, because I think people don't know this. If you don't have an expansion and you are a new mom, you lose your eligibility, and these are the eligibility levels for women on Medicaid. They have to basically, if you live in Alabama or Texas, if you earn more than $3,740 for a family of 3, you make too much to qualify for Medicaid. Okay? The federal poverty level is $20,780. Okay? So we don't really talk, we talk about like, oh, well, you have to go back to these levels. You have to be so poor. And these are among the most needy women that we have who really need the resources and where breastfeeding support services would really make a tremendous difference. So back to our regularly scheduled program. Because once they have Medicaid, a lot of states do cover, I'm sorry. Puerto Rico's not on this map. I'm sorry, but it will be on my next one. I don't think actually it was part of our survey, but it will be part of the next one. This shows the state Medicaid coverage, because they actually aren't required under the traditional Medicaid program. There aren't a lot of actual requirements for this, but you can see that a lot of states, 30 states, said that they covered both electric and manual pumps. But you do have 6 states that we surveyed, and 10 of them didn't respond, said that they didn't cover either electric or manual pumps with Medicaid. Tell us what Puerto Rico does.
85% of children under the age of 5 are eligible for WIC.
No. I'm talking, but
85% of all of our children are eligible for WIC.
And so they're
so
moms.
WIC is considered to be the Medicaid provider of pumps. That's how they get around it.
that's how they do it. Well, yes. That's amazing, 85%. Okay. So the other thing, though, that is important to look at is they do apply these utilization controls requiring prior authorization or limited to moms whose kids are in NICUs or in critical care, or some of them have quantity or time limits. Like, I don't know what you're going to do with that breast pump. Like, after that 4 months, you have to give it back. There are certain conditions that determine the rental, or some of it they will only let you rent the pump and they won't actually buy a pump. So this is really, the states are able to do this under their Medicaid. Oh no, what just happened? Yes, okay, I turned it off, that's why. And then the other important part of this is, availability of lactation consultation. And so we were trying to talk in the positive earlier, but I do want to point to the column in red where 13 out of the 41 states had no breastfeeding education as part of their Medicaid program. And we can see here that there's much more likely to cover consultation in the hospital setting and much less likely to do that in a community-based setting once a woman leaves the hospital. And it's kind of flies in the face of everything we know, where a lot of women intend to, but really where things really fall apart and where they could really use support is once they get out of the hospital and back into the community. And so we know while these supports are actually relatively inexpensive, I work on a lot of healthcare issues. I mean, this is such a little bit of money when you look at what overall the healthcare costs are for maternity care and what we pay for in NICUs and all of the other services. This was a study that was done by Milliman for Medela, which is, I just want to say, it was an industry-sponsored study, but they calculated that for a typical commercial plan that the breastfeeding supplies, the support and the counseling equal 14 cents of a typical $500 premium. 14 cents. So let's say even like you think they're exaggerating, maybe it's like $1, right? It's such a little bit of money. Similarly with Medicaid, and recently you may have read about Anthem, which slashed their reimbursement with their medical supplier, basically limiting, they slashed it by 44%. They used to pay $169. Now they're only going to pay $95 for breast pumps. So, as somebody who has traveled on United Airlines and pumped under a blanket, like, you want like a breast pump that works. I mean, this makes a really big difference to have a high quality, quick pump. So, now I was doing research. There's this new one. Have you heard about this Willow? Has anybody? It was like, oh, I wish I had that, right? It looks amazing. But, and this would really help. This could help a lot of women. This is not a lot of money. However, this is going to leave a lot of women who want to have more efficient pumps really left with either paying for it out of pocket or relying on a less effective pump. And that's because insurers now, they can use many approaches to limit utilization. And this is part of the regulations. And these are very important words. They say, the federal regulations say that insurers can use reasonable medical management. And they can use that to really set frequency, method, treatment, or setting. If there basically are no specific guidelines there. And for a lot of things, we don't have specific guidelines. And I serve right now, I saw Dr. Lawrence here on the WIPSI. Was he here? Is he? He's right up behind there, yeah. We have had these discussions, right? If you don't have the specificity, and it's very hard to have that level of specificity around breastfeeding because there is so much variation, that the insurers do have a lot of power there. And the National Women's Law Center actually has a hotline called Cover Her. It's for women to call if they have problems with their insurance relating to coverage of benefits. And they found all sorts of women experiencing all sorts of restrictions and limitations on breastfeeding supports and insufficient networks of lactation consultants, so that women had to actually pay out of pocket if they wanted to go out of network, even though their network was inadequate to provide the services for them. So again, this is an area of oversight. Insurance commissioners can make a difference, but women need to complain and file these appeals. And we know, like at this period in women's lives, like one more thing to do is like to fight with your insurance company. They just don't do it, and I think a lot of women just give up on this. So looking ahead, and I'm definitely going to have some time for questions here. We see a lot of paid leave efforts gaining momentum, I think, at the state level, but I don't likely see, despite the talk, of action at the federal level. I think that there's a lot we can do in terms of assuring compliance with workplace protections and doing work with employers to educate them, and also to educate women about their rights and what they're entitled to. I think that the ongoing efforts to repeal and weaken the Affordable Care Act protections is likely to really place a lot of the advances that we've had at risk, both in terms of eligibility for coverage and in terms of the scope of coverage. These short-term plans are not going to include maternity care. They're not going to include preventive services. Those are going to really fall short for the women who sign up for them. Medicaid expansion, still an option in many states. As I said, Virginia and Maine have expanded. There's conversations in Idaho, Utah, Nebraska. They could be next. And I think that there's still really an important role for oversight and enforcement of the plans, both at the federal and at the state level, which would really allow more women to take advantage of the benefits to which they're entitled. And I think we still do need to have more research on the impact of these policies, really to demonstrate that they make a difference, because I think that that will empower others to, other states to expand policies and to strengthen the ones that we have. So with that, I will open it up for questions, comments.
Hi again, Lucy Sullivan, 1000 Days. So we advocate on healthcare from the breastfeeding lens, mom and baby lens, as well as paid leave. So I think all of this is exactly spot on, and thank you so much for the commercial break on Medicaid. I really appreciated it. So we are, everybody talks about how we're in a challenging environment, but the environment's going to change, right? Because that's what happens. And with the potential slew of women candidates that will hopefully all be swept into office come November in the midterms, I think there's an opportunity to put some bold proposals out, whether they get traction and pass and whatever. But now is, I think, the time to start thinking about these proposals and start pitching them. And so what would you recommend to a group like us? And is there, are these conversations happening? I know we're all in defense, playing defense and protection.
I work in, most of my time has been sucked up by reproductive health. So I totally get what you're talking about, because there's a lot of defense to play at this. But I do think we need to be ready offensively to kind of get started, because I do think things are going to change. I do think these issues with more women hopefully being elected, I think we still need to do a lot of education. Just because it's a woman doesn't mean that she's good. I mean, we heard today about Virginia, and there's many examples, really to educate our policymakers in general about the importance of these issues. I think it is a good time. It also feels good, honestly, to be planning and thinking strategically about what the next step is. I think there should be efforts at the state level. I think that it's ripe. I think a lot of the paid leave issues, I think, is really kind of ripening. And I also think that this is, this would be a great forum to do this, and also, but also coalitions with other groups that are working on these. So yeah, I say this is a good time.
Thank you.
2.5 more years. And
I
think that also
November.
Well, there's,
and then,
yes, but there's also, yes.
Let's start.
Let's start November. I live in California. We had a pretty good night last night. I was a little scared there, especially when I called my son in Southern California, and I said it was on Monday, and I said, "You're voting tomorrow." He just turned 18. He's like, "Mom, the election's in November." I'm like, "No, it's tomorrow." And you're in Orange County, and you better show up. Anyway, so.
Hi, short. Let's move that down. Ruth Martin with Moms Rising. We are an advocacy organization of over 1 million members across the country working on a lot of the same things that you guys are working on, but more from the grassroots angle. So we use your research all the time and are so grateful for you guys putting it together and for inviting us here. So I also wanted to thank you because a big thing that we work on is actually, the team I lead is called our Workplace Justice League, which is about making sure that we have these kind of accommodations. So I just wanted to put in another plug to say that with a slightly different angle, you guys are professionals and medical professionals and researchers, and your voice carries so much weight when we are trying to do this work at the state and national level, when you come in with your expertise and your data. And so Lucy mentioned this, there's a lot of coalitions, you mentioned it too, both at the national level we will win this eventually. There's growing consensus that we need family, or at least parental leave for babies. We need to make sure that we have it for other reasons too. And there's a lot of momentum at the state and local level too. I think Massachusetts is about to pass paid family medical leave, hopefully in a few weeks, and if not then, in November, and a handful of other places too. So I just want to say that two things. You guys have stories that are super important, and if you are willing to engage in some of these efforts in whatever capacity you can, folks like Lucy and I are happy to help plug you into coalitions at the state and national and local level that can use you. Two, if you need stories to go with your data points, the real stories that make you cry about breastfeeding stories, stuff like that, we have those, a lot of them, and are happy to help provide them to you because the data is so important, and sometimes partnered with a good story, it can be even more compelling and pack a 1-2 punch, and we'd love to help you guys get that stuff. So those are things I want to say. Thank you so much for all of your work. It's so important.
Hi, Michael Young with Howard University and the National Medical Association. What other metrics whenever we talk about family leave and women's leave, postpartum leave, father's leave, a lot is thought about people who are in salaried positions, but your wage earner doesn't get included in that, and that population still needs to have leave as well. What are the financial metrics? Because there's always this big pause, especially from our small business folks who like, I can't afford it. So how do other countries do it, and what are the financial metrics of it?
So there might be other people who are better qualified to answer that here because I haven't worked with that. But in California, for example, all the employees actually pay in. It doesn't really cost the employers anything. I mean, there's many different ways to structure it, and it doesn't have to be burdensome for employers to do that. So I don't know.
I'm an example. Our
yeah.
publishing company,
Yeah.
we publish the ABM
Yeah.
Journal. Implementation in New York State has now required us as an employer to take out $1.12
Yeah.
from each paycheck, from each employee that pays for a pool to cover that.
Yeah, it's not
much.
expensive.
Right.
It's really not
When you
that
spread it over a
expensive.
population, it's
Yeah.
not expensive, and it's really an important investment. I wanted to both urge all of you, from what you hear today and the positions that you hold and bring today, to take this kind of information that Alina has just provided and hopefully energize all of you to play your role in your states with your state, local, and federal leaders. Give them this information, not long. I think it was Oscar Wilde who said, I didn't have time to write you a short letter, so I wrote a long one. Yeah. Write a short one. Write a short letter. Use this information and get them to pay attention to the bills. You'll hear about some of them today and tomorrow. You just heard about some of the issues, but your voices are really important, and that's why we invited you here. The other is that, as some of you will remember, that the proceedings from this summit, like the other 9, will all be published electronic and in print, sent to every member of Congress, sent to the president's desk, sent to every governor, sent to you, sent to every Kellogg grantee, sent to other political and nonprofit leaders around the country. So you have the information literally in your hands to be able to use it and promote it and help affect legislation that is really, really important. The other piece in terms of our roles, in terms of the power of the positions we have, the organizations we represent, is the coalitions we can build together, which are hugely important. It's one of the reasons there's no speaker at lunchtime. It's so you can speak to each other because you're so important. And one specific activity that I just want to highlight, because it's come up twice so far already, is the response to Anthem's coverage. ABM, ACOG, and AAP have gotten together and wrote a letter to the president of Anthem and are getting them to look at this policy, explain to us what it meant, not rumors, not leaks, not nothing. What are you doing with this? And have gotten a lot of clarity about that. And we have the power of that voice to be heard and meet with the heads of Anthem to change that. Well, it's not change it, it's clarify what that means and to make them understand the implications of it. So again, it's the power of the voice that you have and the power of the information you're getting here and tomorrow.
And I think it's really important to stop, like, to nip these things quickly because, Anthem does this, United, Cigna.
Absolutely.
I mean, if they see that others are they can do this without a lot of, creating a lot of waves.
Exactly.
It will.
And we have the power to
It will
educate
happen.
and change or stop things that are harmful.
Yeah. Thanks.
Hi, thank you so much. I'm just getting into the policy field of breastfeeding. I'm really academic, and so this is really helpful. I have a quick question about childbirth doula coverage, not only from a maternal and infant mortality comorbidity perspective, but also from breastfeeding, because the research is there to show that it is successful. So in terms of getting insurance coverage, not only private plans, but also for Medicaid, is there momentum there? Is there increasing in momentum? I know New York just had.
Some states do cover it, but it's really, it really varies, and the same for insurance. And I would say probably more don't than do. And I think that, again, this is, I think with insurance and I think with Medicaid, it's making the case that it's going to save money or improves health, that it's medically, you really have to, there was I thought, really compelling piece in the New York Times around the maternal mortality and the important role of doulas. I thought that was a very compelling case for why something that's basically a very inexpensive program can really make a difference. And then, kind of how do you translate that and make those stories policy? And that's really the key. More research, so there's still stuff for you to do.
So I mentioned that yesterday I spent the day with the food industry. So I wonder if we want to spend a day with the breast pump industry. And Kaiser could pull the breast pump companies together, and Kaiser could help maybe have the sign-on letter from the breast pump companies that something that Anthem is doing or Medicaid not expanding is hurting their bottom line. So I wonder if anybody's
I don't think you need Kaiser to get the breast pump people to talk to you.
No, well, I can't get them to talk to me.
No, you
as a
can.
fellow
CDC can't,
right,
but I think that you can't. You
Right.
can't.
So
I think you have to be careful with that particular strategy in general, because I think people look at industry with a lot of, and understand it, like they want to make money on this. So I think that to the extent that you can get independent voices, research community, advocacy, grassroots, to talk about why this matters, I think on some level will move the policy dial in a way that the industry can be saying, well, it's just the insurers will be like, it's just the industry, they want to get paid. So it's
Well, it's interesting because yesterday the comment was public health's always talking to industry and industry's always talking to public health, but neither one of us is really listening to each other.
Yes,
So
yeah.
I think there's a win-win for everybody, not to say the industry's good and the rest of us
No,
crazy
no, I
people.
understand. I think that as
I'm
part
not
of a
saying-
coalition,
Right.
I think that that's an important thing. But I
Agree.
think that the power of this is kind of, is my opinion.
For those of you who are not familiar how maternity leave works outside of the United States, the cost is, it's a Social Security benefit. So it's part of the Social Security tax, and the payment is from the Social Security agency, pegged to the income that you have, up to some maximum, but surely it covers most people. It's not just a minimum wage, and it's for each country sets its limit of time. It'd be 3 months, 6 months, 12 months, or something like that. So there's no loss of income, and it's not out of the employer's pocket. So it's you talk as this is a basic right. I think we should just mention that the country that has probably among the most generous maternity leave benefits has one of the lowest rates of breastfeeding. That's France. And therefore, we should also put our continuing breastfeeding beyond the neonatal immediate postpartum period in a cultural context. Maternity leave is not the one and only variable
No,
here.
and nor.
I'm sure everybody knows that, but we tend to fall into that trap. If we just get the coverage that goes on in other countries, we'll solve the problem. It's in the cultural context. And
Yeah, I
think-
mean, it's an enormously complex puzzle. I mean, I have to tell this group, but I feel like, similarly, I get this, like, well, if just because insurance covers it. It's, some of these things are kind of necessary but not sufficient, and I think that, having this undergirding of support, I still think is critical. Okay.